Thank you so much for always being with us, our students. And in this session, we are going to look at antifungals, drugs which are used to treat fungal infections. And fungal infections are categorized into topical, that is dermal, then we have systemic, then we have cutaneous and sometimes subcutaneous. So we want to see drugs which are used to treat these infections. We shall look at the side effects of drugs and the drug interaction. And as we begin, if it is your first time, please subscribe. It is the only way you can support us so that we can continue to make more videos. Then remember to like the video. So antifungals, we are going to look at different categories or categorization, or you can call it classification. We can classify antifungals according to the disease which they target, if it is systemic or topical or cutaneous. We can classify them according to their mechanism of action and also according to the source, if it is either natural or synthetic. So in this session, we are going to start by classifying them according to mechanism of action. And these antifungals, they target different pathways in a fungal, and we are beginning with those which target the cell wall. The fungal cell wall is made up of a phospholipid bilayer, and the cell membrane is made up of phospholipid bilayer. But the cell wall has other components like the beta 1,3-glucan, which stabilizes the cell wall. It also contains a component known as the ergosterol. And this ergosterol is derived from cholesterol. You know, in cell wall of animals, they contain cholesterol, whereas the fungus contains the ergosterol, which stabilizes. So together with the ergosterol and the beta-glucan, they enable strengthening of the cell wall. So they maintain the integrity of the cell wall of the fungus. So we want to see how different drugs can lead to the death of the fungus by targeting these two components that strengthens the cell wall of the fungus. So how are they formed? For example, the ergosterol, we are saying it is derived from cholesterol. That if we have cholesterol, it is converted into a component known as squalene. And this squalene is oxidized to lanositol. And this lanositol is the one that is converted to the ergosterol, which is transported to the cell wall to increase its integrity of the cell membrane. And we are going to see that the process of converting squalene to lanositol is catalyzed by an enzyme known as squalene epoxidase. So this squalene epoxidase, before it forms the lanositol, it first forms squalene epoxide. Then this squalene epoxide is the one that is converted into lanositol. Then lanositol is converted into ergosterol, which is transported to the cell wall. So we want to see different drugs which target different mechanisms. The conversion of squalene epoxide to lanositol is then, after lanositol forming, to form it into ergosterol, we need an enzyme, and this enzyme is known as cytochrome P450 alpha demethylase. This is an enzyme. And this enzyme targets at carbon 14 of ranostol. So if we have cytochrome P450 alpha demethylase enzyme, it targets at carbon 14 of the ranostol, lead by removing a methyl group at ranostol at carbon 14, then we form a gastro, which forms the part of the cell. So we are going to see two categories of drugs which target this synthesis of ranostol and a gastro, which forms the integrity of the cell. And one of the drugs which targets the squalene epoxidase is known as terbinafine. We have terbinafine is the most common drug being used, but we also have butenafine as a drug. We have also naftifine. So these are the three drugs which act by preventing formation of a gastro by alternative pathway, inhibiting squalene epoxidase enzyme. So if I don't form squalene epoxide, I cannot form ranostro. Without ranostro, I cannot form a gastro. And without a gastro, it will create pores in the cell wall, leading to leakage of the intracellular contents such as hydrogen ions and potassium ions, leading to the fungal cell death. Then the next category of drug we are going to talk about is the drugs that inhibit cytochrome P450 alpha demethylase, which prevents it from removing methyl group at carbon 14 of ranostol to form a gastro. So those drugs include, the category of drugs that act by inhibiting this enzyme, which converts ranostol to gastro, we are going to call them azoles. Because after inhibiting formation of a gastro, we shall not be able to form a gastro within the cell wall, which will create pores, polynes, small pores in the cell membrane due to lack of these gastros in the cell wall, leading to fungal death due to the leakage of intracellular contents. So meaning terbinafine, these alkylamines, the terbinafine, butenafine, naftifine, together with the azoles are both fungicidal. They both kill the fungus by interrupting the integrity of the cell. And these azoles, which are limiting or inhibiting formation of a gastro from ranostol, include, and they are categorized into two. We have the imidazoles. We have the imidazoles. We have two categories of azoles, whereby one category we call them the imidazoles, and then another category we call them the triazoles. So they all end with azo suffix, those which inhibit formation of a gastro. And examples of imidazoles include ketoconazole. We have ketoconazole. We have miconazole. We have clotrimazole. We have iconazole and oxconazole. These are some of the examples of the imidazoles, which act in this way by inhibiting formation of the gastro, leading to fungal cell death. And among these imidazoles, with the exception of ketoconazole, for it, ketoconazole targets the systemic fungal infection, whereas the miconazole, the clotrimazole, iconazole, and oxconazole, for them they target topical infections, or what you can call superficial, such as the dermatophytes and oral candidiasis, including oral candidiasis, esophageal, together with the vulvovaginal candidiasis. So these ones look at the topical fungal infections, whereas the ketoconazole is the only imidazole which deals with systemic fungal infections, as we shall see in indication. Then the triazoles, for them they are purely systemic. Triazoles, for them they target systemic infections, fungal infections, and examples of triazoles include we have fluconazole, we have itraconazole is also an example. Then we have posaconazole, then voriconazole. So these are the examples of triazoles which deal with systemic infections such as blastomyces, histomycosis, and coccidioidomycosis. So these ones, especially the itraconazole, is a drug of choice for treating the histomycosis, the blastomycosis, and the coccidioidomycosis. They are the drugs of choice, especially the itraconazole. But also fluconazole can be used, as we shall say. So these are the two categories we have already seen. And terbinafine for it is most commonly used to treat fungal nail infections known as onychomycosis. The dermatophytes that target the nails, they can be the nails of the hand or of the feet. So the fungus that affect the nails are treated best using terbinafine, though it can also be used to treat different tinea infections like tinea capitis, tinea pedis, but it is a drug of choice for onychomycosis infections that target the nails. Then another category of drug that targets the cell wall, apart from the terbinafine, which are alkylamines, apart from the azoles, we have also the beta-glucans. But before we go to the beta-glucans, we have also another category here known as the polyenes. These ones, we can call them polyenes. These are antibiotics. And for them, they target by binding to the ergastro. For them, they bind. The polyenes bind to ergastro in the cell wall. After binding to ergastro, they create pores in the ergastro, leading to the leakage of intracellular contents such as potassium and hydrogen, leading to fungal cell death. So how do the mechanism of action of the azoles differ from the polyenes? The azoles prevent formation of ergastro, so it cannot be incorporated in the cell. Whereas the polyenes, for them, they bind to the ergastro, which is already in the cell. And when they bind, they prevent it by causing pores, micropores, hence leading still to the leakage of intracellular contents. And examples of polyenes include nystatin, which was the first one, nystatin. Then we have also amphotericin B. And these they are antibiotics. This nystatin is also used topically to treat topical fungal infection, whereas amphotericin is has a broad spectrum of activity, but most commonly used for systemic fungal infections, those which are severe. And that is amphotericin B, which binds to ergastro, leading to formation of pores in the cell wall, leading to leakage of intracellular content, hence leading to fungal cell death, meaning it is also fungicidal. So this is pseudo, these are pseudo. So all the antifungals which target the cell wall causing pores, they are fungicidal. Then after looking at that, we shall come back to it. Now we want to look at another category of drugs which target these red components in the cell wall. And these red components in the cell wall, we are calling them beta-glucans. And these beta-glucans are synthesized inside the fungal by an enzyme known as beta-glucan synthase. Beta-glucan synthase. So it is the one that enables their synthesis, this enzyme, and after being synthesized within the fungus, they are incorporated within the cell wall, hence making the cell wall very stable. So there are certain kind of drugs which we can use to inhibit the beta-glucan synthase enzyme, hence we cannot form these beta-glucans within the cell wall, hence creating pores leading to the leakage of the intracellular content. Because without the beta-glucans, the cell wall cannot be intact. The pores will be there, leading to the leakage of the potassium, hydrogen, and other intracellular contents, leading to fungal death. And examples of the beta-glucan we have, the example of the enzyme, the drugs which are beta-glucan inhibitors is the echinocandins. It is a new type of drug known as echinocandins. And these echinocandins include examples of drugs such as caspofungin. They end with the suffix fungin. We have mycofungin. These are certain drugs which are echinocandins, and they bind or act by inhibiting beta-glucan synthase, hence leading to lack of the beta-glucans in the cell wall, leading to fungal death. So these are some of the examples, the caspofungin and the mycofungin. So whenever you find a drug ending with the word fungin, you know that those are the echinocandins. These are the newly discovered drugs. Newly discovered drugs which can be used in the treatment of fungal, that is especially candidiasis, which is resistant to other drugs, whereby we can use these echinocandins in IV form. They are intravenous given. Then, after looking at all the category of drugs which target the cell wall, that is the azoles, the polyenes, then we have the terbinafine, the butenafine, and naftifine. Then we have looked at the echinocandins. How do I know that they are azoles? They all end with the suffix azo. All of them, they end with azo. And how do I know that these are squalene epoxide inhibitors? They end with the suffix fine. All of them end with the suffix fine. So the second last category of drug is also what we are going to look at here. This drug, it is an antimetabolite. This one we are going to call it an antimetabolite, whereby it is going to prevent, it acts by inhibiting. This is the DNA, and sometimes we have the RNA in the cell, in the cytoplasm. So this antimetabolite, which we are going to call 5-flucytosine, 5-flucytosine is an antimetabolite, which is always a prodrug. But once taken, 5-flucytosine is converted to 5-fluorouracil. Fluorouracil. You can abbreviate it as 5-FU. And this 5-fluorouracil, which is the active metabolite of 5-fluorocytosine, when incorporated, it is going to inhibit an enzyme responsible for the synthesis of pyrimidines, that is thymidinate synthase. So it is going to act by inhibiting enzyme known as thymidinate synthase, leading to the failure to form the pyrimidines, which are used in the synthesis of DNA and RNA. So that's why we are calling it an antimetabolite, and its mechanism of action is to form the active metabolite 5-FU, which inhibits thymidinate synthase, hence leading to failure to form the pyrimidines that participate in the formation of DNA and RNA. So, meaning this drug is not fungicidal, it is fungistatic by preventing cell division of the fungus. And this drug, we shall see its major side effects, and it is being used in combination with amphotericin B in treating cryptococcal meningitis, because 5-fluorocytosine can cross the central nervous system, that is blood-brain barrier, whereas amphotericin B cannot cross the CNS. So when we give them in combination, this one will enable entry of amphotericin into the CNS, hence producing synergistic effect. So a combination of 5-fluorocytosine and amphotericin are being used in treatment of cryptococcal meningitis. First, then we continue with fluconazole. Then the last category of the antifungal is glycoflavin. We have glycoflavin is the last category, and this glycoflavin, for it, its mechanism of action is by inhibiting mitosis. It inhibits mitosis, that is type of cell division, by binding to the microtubules. So during cell division, the microtubules holds the sister chromatids at the equator of spindle. So what the glycoflavin do, it comes and inhibits, binds to the microtubules. And when it binds to the microtubules, it is able to prevent cell mitosis, which is a type of cell division, and hence the fungal infections, the fungus cannot be able to multiply. And it normally targets the fungal hyphae. So it prevents formation of the fungal hyphae. That's why we are saying it is fungistatic, and majorly used in treatment of dermatophytes. If the imidazoles fail, that is the miconazole, clotrimazole, iconazole, and oxaconazole, together with nystatin, we can use glycoflavin to prevent their multiplication by preventing fungal hyphae multiplication. That is glycoflavin. So, now, according to our discussion, we have seen that whereby our category number 1 was the drugs that inhibit formation of squalene epoxidase, that was terbinafine, butenafine, and naftifine. The second one, we looked at azoles. The third one, we looked at polyenes. Then we looked at beta-glucan, that those are the echinocandins. We have looked at the antimetabolite as number 5. Then number 6, we have looked at the glycoflavin, whereby 5 and 6, they are fungistatic, whereas 1 to 4 are fungicidal. So this is what we can categorize them according to their mechanism of action, whereby we have the squalene epoxidase inhibitors, we have the gastrosynthesis inhibitors, we have those that bind to the gastro in the cell wall, that is the purines, which are antibiotics. Then we have the beta-glucan synthase inhibitors. Those are the echinocandins. We have antimetabolites, that is the 5-flucytosine. And we have mitosis inhibitors or microtubule inhibitors, that is the glucofuravin we can talk about. So briefly, we are now going to look at their indication and some of the side effects as we conclude. Please remember to like this video and sharing to many others. So let us begin with the azoles. And as we said, these others, except ketoconazole, which is systemic, others, the miconazole, clotrimazole, and iconazole, are used for topical, plus the oxconazole. Topical infections like the oral candidiasis, oral esophageal, and vulvovaginal candidiasis. They can be used, whereby they are used as cream, as suspension, or pessaries in treatment of these candidiasis conditions. But not forgetting also topical fungal infections like the dermatophytes. We can also use them to treat dermatophytes. Dermatophytes, which we call tinea, like tinea pedis, that is the one that affects the head. That is tinea capitis. We have tinea corporis, tinea cruris, and tinea pedis, that affect feet. So all tinea infections, those are the dermatophytes. We can use these imidazoles. But if the imidazoles fail, we can easily use glucofuravin to treat them. And if they fail, we can use this broad spectrum like amphotericin B to clear them, or tabinafine. But then this is what we can see here. But the triazoles, for them, they are used for treating systemic infections. And as we said, like itraconazole is used for stomatitis, blastomycosis, and coccidiomycosis infections. Itraconazole being the drug of choice, but we can also use fluconazole to treat these infections. But fluconazole as a drug, it is a drug of choice for treating candidiasis, especially invasive candidiasis, and also treating of cryptococcal meningitis. And fluconazole is used in immunocompromised patients like HIV patients as the prophylaxis. So if you have ISS patient who is at risk of developing fungal infections, you can give fluconazole as a prophylaxis. That is what we can talk about. For saconazole and voriconazole, they have broad, widest spectrum of activity, and they are used when the fluconazole and itraconazole have failed. That's when you can use the posaconazole and voriconazole. And their major side effects of azoles is that they are cytochrome P450 inhibitors. So if you take these drugs with like warfarin, because they are inhibiting cytochrome P450 enzymes in the liver, they are going to cause that drug to increase in concentration like warfarin, leading to excessive bleeding. So you cannot take it in combination with warfarin because they are cytochrome P450 inhibitors. And apart from them, they also can cause photosensitivity. They cause photosensitivity and hepatotoxicity. But with the peculiar of ketoconazole, for it can cause gynecomastia. It can cause menstrual irregularities in ladies, and it is not advised to give ketoconazole together with oral contraceptives. And its absorption is highly absorbed in the presence of fatty meal, but don't give it with antacids. So it can cause gynecomastia and menstrual irregularities. That's why most doctors currently, they no longer prescribe ketoconazole because of its much side effects. So to prevent these side effects of ketoconazole, doctors have resorted to other forms rather than using ketoconazole in treating of systemic infections. We rather go to fluconazole and other drugs because of its major side effects. Then what are the adverse effects of amphotericin? Amphotericin, its major side effect, it causes phlebitis, that is swelling of the blood vessels. Then it leads to nephrotoxicity. So to prevent nephrotoxicity, you can give it together with normal saline infusion to reduce on the risk of nephrotoxicity. It causes hypokalemia, that is reduced levels of potassium. It also causes hypomagnesemia, that is low level, it reduces levels of magnesium. At the same time, it can cause hypotension. That is the side effects of amphotericin B. So amphotericin B has much side effects. That's why it is always a last resort in the treatment of resistant or severe fungal systemic infections, because for it, due to its high side effects. Then terbinafine, its side effect is hepatotoxicity. These ones can cause hepatotoxicity. So when using them, we must monitor the liver by doing LFTs. But when using amphotericin B, you have to monitor patient by doing serum electrolytes and doing renal function tests so that you monitor if they are being affected. That is very important to note as a pharmacist. Then another category of drug is the echinocandins, which we said they are newly formed drugs, which are also being used in the treatment of some systemic fungal infections. And these echinocandins, they are a drug of choice for treating aspergillosis and also candidiasis, which is resistant to other drugs. So candidiasis and other dermatophytes which are resistant, we can also use echinocandins, but it is the drug of choice for treating aspergillosis. That one you have to note as echinocandins being a drug of choice. It can also cause hepatotoxicity and other side effects like nausea, flushing, vomiting, diarrhea, and other GIT disturbances. But the specific one is that they can cause hepatotoxicity. So you have to give them as you're monitoring the liver functioning of the patient. Don't forget, it is a drug of choice for treating aspergillosis infection. Then we go to antimetabolite, which we are causing 5-flucytosine. 5-flucytosine, as we said, we are using it in combination with amphotericin to treating cryptococcal meningitis. Then after doing that, we continue with the fluconazole. So if you discover cryptococcal meningitis in a patient, you give a combination of amphotericin B together with 5-flucytosine because they produce a synergistic effect. As I said, this can cross the CNS, whereas this one cannot cross the CNS. Then after 2 weeks, you continue with the fluconazole for better treatment of cryptococcal meningitis, because the fluconazole also has ability to cross the CNS. That is very important. Then the side effect of flucytosine, that is adverse reactions, is majorly bone marrow suppression. This one causes bone marrow suppression, so patients can suffer from what we call pancytopenia. Pancytopenia that is characterized by reduced white BC count, reduced platelet count, and anemia. So because they suppress the bone marrow, this 5-flucytosine is going to lead to all cell lines reduced, that is white blood cells, red blood cells, and platelets, a condition we are calling pancytopenia. And apart from that, this antimetabolite, that is 5-phosphatocytosine, is teratogenic, so it is not encouraged to use in pregnancy. If you have a pregnant mother or breastfeeding mother, you are not allowed to use 5-phosphatocytosine. You can resort to only amphotericin or fluconazole for treatment of Cryptococcus meningitis. Why? Because it is teratogenic and also it is hepatotoxic. It can also damage the liver. Those are the specific side effects of 5-phosphatocytosine. That is being teratogenic, not used in pregnancy. That is also causing bone marrow suppression, and at the same time alopecia, that is loss of hair. It can also cause hair loss known as alopecia. That is because it is inhibiting DNA and RNA formation. Also, glucocerebroline, which we said it is also being used in treatment of dermatophytes like the Tinea capitis, Tinea pedis, Tinea cruris, and Tinea corporis. Those which have been resistant to the imidazoles, we can use glucocerebroline. Actually, glucocerebroline is also used to treat mucocutaneous fungal infections. And the side effects of glucocerebroline is also it is teratogenic, contraindicated in pregnancy. It is also hepatotoxic. So it is not given in people with any liver disease. That is glucocerebroline. So majorly this is what we can discuss with. As a student, what you need to know is the mechanism of action, the indication, and the side effect. And this glucocerebroline, it is also cytochrome P450 inducer. So given with other drugs, because it induces the enzyme, it has ability to decrease other drug concentration because it induces the cytochrome. So remember, azoles are cytochrome inhibitors, whereas glucocerebroline is a cytochrome P450 inducer. So this is what we can discuss with you in this session. Hope you have gained something from this video. Please remember to subscribe, like, and share to many others. Thank you so much.